of a very interesting topic. We are going to focus again and wrap up with the newest guidelines and the changes and the up-to-date management of both lupus nephritis and ANCA-associated vasculitis. We have three great speakers today. Our GN board member, Professor Bianca Davidson, is going to give you updates about the 2024 KDIGO guidelines for ANCA-associated vasculitis and what was different from these guidelines and the previous guidelines. Dr. Seth Brex from Manchester, United Kingdom, is going to give you also some background about the new complement inhibitors, especially the C5A, the Evacopan, the FDA-approved complement inhibitor for ANCA-associated vasculitis. And Dr. Juan Mejitvalet from Mexico is going to talk to you about the role of complement inhibitors in lupus nephritis. I am very sure that you will enjoy their talks, and we are all going to learn a lot from them. And with that, I'm going to leave you to listen to the lecture.
Hi, hello, my name is Dr. Davidson. I'm a clinical nephrologist working at Curtis Care Hospital in Cape Town, South Africa. I was asked today to give you a talk on an update surrounding the management and treatment guidelines for ANCA vasculitis. This is in addition to the talk in your syllabus about ANCA vasculitis. Okay, let's begin. All right, so we've all seen patients with ANCA vasculitis, and I think it's essential as trainees and as young nephrologists that we have a firm grasp on how to manage and treat ANCA vasculitis, as these are very sick patients. Management guidelines for ANCA vasculitis was covered in the 2021 Clinical Practice Guidelines for the Management of Glomerular Diseases, but a revision was released in early 2024, and the talk today will be about what those changes are. So the first question we should always ask ourselves is what prompted the revision of the guidelines? And in an editorial that is published that I've shown below, there was approval of C5A inhibitor by the FDA and the European Medicines Agency, so the use of Evacopan is much more widely available as an add-on to standard care. There also in these guidelines is a stronger emphasis on lower steroid dosage usage, and this is following the results from the low-VAS trial. For the format of this talk, we will review each section of the revised guidelines and see if that section has any changes to it. If changes have occurred, we will look at the studies that are behind the changes. For the section of diagnosis and prognosis, there were no changes made, so the recommendations remain the same. If there's a clinical diagnosis of vasculitis with serology that confirms ANCA vasculitis, treatment should not be delayed for a biopsy or for biopsy results. Treatment should be offered in a center that has expertise in ANCA vasculitis, and serology does play a role in prognostication. So the presence of ANCA after induction treatment, an increased level or titer of ANCA, or a change from negative to positive is predictive of a future relapse. Moving on to the section of treatment recommendations, we now find that changes have occurred. So the recommendations for treatment have changed slightly. Recommendation 9.3.1.1 hasn't changed. They still recommend the combination of glucocorticoids with either rituximab or with cyclophosphamide as initial treatment. What you can see here is that Evacopan is added to the treatment guidelines, and there's a stronger emphasis on reduced glucocorticoid doses. There still is a recommendation 9.3.1.2, which is a subgroup of patients with severe ANCA glomerular nephritis with a very raised serum creatinine. In this group, cyclophosphamide is preferred over rituximab, as there is limited evidence for rituximab in the subgroup, and they do advocate for a combination of cyclophosphamide and rituximab in the setting of severe ANCA glomerular nephritis. How to base your decision on whether to choose between cyclophosphamide or rituximab hasn't changed. You can see that the framework below is exactly the same as that used in the 2021 guidelines. So let's take a minute to talk about why Evacopan has been added into the guidelines. I mentioned before that it's more available due to the FDA approval, but when we are discussing the trials behind what this guideline is based on, you will find two major RCTs. The first one is the Advocate trial. The working group felt there were no methodological concerns with this trial. However, the Classic trial, which is also an RCT, had a high dropout rate, and there was changes in the priori primary outcomes. The working group considered both trials and decided to make Evacopan a practice point and not a recommendation. Right, so let's go a little bit deeper into the Advocate trial. This paper was published in 2021, and the study had 331 patients that either received cyclophosphamide or rituximab. They were assigned to either an arm receiving Evacopan at 30 mg ED or glucocorticoids at 60 mg tapered to discontinuation at 21 weeks. The outcomes was to see whether Evacopan was superior or inferior to glucocorticoids, and they based this on clinical remission at 26 weeks and sustained remission at 26 and 52 weeks. And what the study showed is that Evacopan was not inferior to glucocorticoids. So there were two post-hoc analyses that were done from the Advocate trial. The first one was to investigate the degree of glucocorticoid toxicity. This falls part of the studies that have broadened our understanding of the toxicity of long-term glucocorticoid use in ANCA vasculitis. There was obviously the mean glucocorticoid use was lower in those in the Evacopan group, 1 gram versus 3 grams. There was less glucocorticoid toxicity index in those that used Evacopan, and no domain in the glucocorticoid toxicity index, which included BMI, glucose intolerance, lipid metabolism, and skin toxicity, favored the glucocorticoid arm. Therefore, there was a recommendation to those individuals that were at high risk of glucocorticoid toxicity to consider Evacopan instead. It also showed that the study also emphasized how nuanced glucocorticoid toxicity is, and a lot of the participants in this post-hoc analysis, although they improved on certain aspects of the glucocorticoid toxicity index, they worsened on others. And the end statement was that multiple measures to identify glucocorticoid toxicity should be used instead of one output alone. The next important post-hoc analysis that came from the Advocate trial was shown in this visual abstract below, where they found that those with a lower EGFR benefited from the use of Evacopan, with a statistically significant change in EGFR and increase in EGFR of more than twofold. So just a quick reminder on the mechanism of action of Evacopan. This is covered in your ANCA syllabus, but just a little reminder. This is a C5A inhibitor. It blocks the autoactivation of C5A, which is a potent complement loop. As this loop is activated, more and more complement is activated, and by inhibiting this, you will decrease the overall inflammation. So Evacopan has got a role in being used in those that are at high risk of glucocorticoid toxicity, and also needs to be considered in the subset of patients with an EGFR of less than 30. I put the slide in just as a reminder for all of us about the dosing of the different drugs. I know that Evacopan is not available in South Africa yet in the state service due to cost, and I'm not sure whether other people have had problem accessing it. So just a reminder about the dosing. It's 30 milligrams per RCD. The second change in the treatment recommendations were about a reduced dose of glucocorticoids. This decision was based on two studies. Firstly, Plexivas, and the corticosteroid dosing chart that I've attached to the slide is that used in the Plexivas trial. What you can see here is that the steroids are reduced to 0.5 milligrams per kilogram by week 2, and after four months, almost each weight category was at 5 milligrams. The low VAS trial recruited patients that were induced with rituximab. They were then randomized to either 0.5 milligrams per kilogram per day of prednisone, or the high dose arm, which was 1 milligram per kilogram per day. The reduced dose glucocorticoids led to similar remission rates, but the frequency of severe infections was higher in the high dose glucocorticoid arm. A limitation of the study was that it was mostly a Japanese cohort with a predominantly MPO ANCA vasculitis. Nevertheless, this data supported the reduced glucocorticoid dose that was seen in the Plexivas trial. So let's take a bit of a deeper look at the low VAS trial. All patients were on rituximab, and there was a comparison that was made between high dose and the low dose steroid arm. What differed to Plexivas was that the low dose arm of the steroids were completely weaned off by 6 months. What were the results? So on the slide below, I have included 3 of the Kaplan-Meyers's. The first one is a time to composite outcome. The composite outcome included death, time to first relapse, end-stage kidney disease, and the first serious adverse event. End-stage kidney disease was defined as dialysis requiring for more than 6 weeks without recovery. Kaplan-Meier shown in graph B was the time to death, and in Kaplan-Meier in labeled C was the time to first relapse. At 24 months, the frequency of relapse did not differ between the two groups, and the serious adverse events were less frequent in the reduced dose of glucocorticoids, with a lower rate that was seen at 6 months after induction. Moving on, the next section of the recommendations deals with plasma exchange. There has been no change in the recommendation about the use of plasma exchange. It still clearly states that plasma exchange should be considered in settings of severe ANCA with creatinines more than 3.4, if the patient is on dialysis or has a rapidly increasing creatinine, or in a patient that has pulmonary hemorrhage with hypoxia. They also say that plasma exchange is essential in a syndrome with overlap ANCA and anti-GBM disease together. I put this slide in. This is from your talk that you have in your syllabus on ANCA vasculitis, because I wanted to just highlight the fact that there is no consensus between the guidelines about the use of both the combination treatment of cyclophosphamide and rituximab and the use of plasma exchange. It is important to note that when cyclophosphamide is used in combination with rituximab, if there is no improvement within 3 months or if the patient remains dialysis dependent, you should consider stopping the immunosuppression. There remains a lot of controversy over the use of plasma exchange in ANCA vasculitis. From a public review of the practice point to use plasma exchange, that the public uptake on this point was low. It was only at 75%. However, the guidelines go on to state that these recommendations are based on a meta-analysis that concluded that there was a reduction in kidney failure at 12 months if plasma exchange was used, and the cost of this outcome is that there is an increased risk of serious infection. They do state that plasma exchange should not be used routinely on patients with an EGFR of less than 50, and that it needs to be considered only on those that have a more severe presentation with a creatinine of more than 3.4, or those that have a pulmonary hemorrhage associated with hypoxemia. And it is essential to use it when there is combined ANCA vasculitis and anti-GBM disease. There are no major changes to the recommendations on maintenance treatment for ANCA vasculitis. You can still consider choosing between rituximab or azathioprine. However, what is clearer with these updated guidelines is that they give a recommendation on duration of maintenance therapy and dosing schedule of rituximab. So that the optimal duration of rituximab or azathioprine should be between 18 months and 4 years. How to choose what the length of time we will deal with in the next slide. They also say that the maintenance dosage of rituximab can be dosed on either a fixed schedule or upon the reappearance of the CD19 cells. They do mention that dosing based on reappearance of B cells leads to fewer infusions and a cheaper overall cost. As far as the duration of maintenance that should be used, they have left it at the clinician's discretion as to the length of time, but they have given pretty clear guidelines as to who should receive the longer dosage. Those that are at a high risk of relapse, which include those that have been diagnosed with GPA, that are PR3 positive, have worse creatinines, more extensive disease, and those with ear, nose, and throat disease. There is no new information to guide clinical approaches to ANCA vasculitis in patients with relapsing or refractory disease or after kidney transplantation. Thus, the content of the 2021 guideline did not change. Once again, there's no additional information about transplantation and ANCA vasculitis, so the recommendation has remained that a patient should be in complete clinical remission for 6 months before a transplantation is considered. Thank you for your time. I hope that makes it a bit clearer as to what the updates to the ANCA management guidelines have been, and I'm happy to deal with any questions throughout this talk.
And detailed overview in complement that makes my job now much easier. So I'm very pleased to talk about the role of complement in ANCA stage vasculitis today. And first, my disclosures. And looking into the objectives for me today, compared to our first workshop with C3 glomerulopathies, where you got a good overview and detail of the KDIGO recommendations in C3 GN. It's a bit different today because the last KDIGO recommendations are drafted before FDA and EMA approval of avacopan. So this will be more about how much do we know is the complement involved in the pathophysiology in ANCA stage vasculitis, and from there, what clinical trial results do we actually have, counting that one big interventional trial. And then I will only touch on what complement inhibition is in or not in KDIGO and the about to be released EULA recommendations. So first of all, it's always the question, why discuss this at all? I think we all know our patients are suffering from multi-organ disorder, and most of them are miserable. And perhaps we concentrate as physicians more on the clinical scenario and the severity of the disease. So we're very worried about diffuse alveolar hemorrhage, crescentic GN. And we could say we're getting better. But if you look at this here, while there's an improvement in survival over the last decades, we are not able to be satisfied. We're far from allowed to be satisfied. If I just concentrate with you on the last Plexivas data here, and we'll just focus on the first year survival, there is a 25% chance that our patients develop end-stage kidney disease or die with rituximab or cyclophosphamide adding in plasma exchange or not. So that is not okay. And it becomes more and more important to reduce toxicity. So again, if we're now looking at reducing steroids here, the long-term outcome might be even better if we use less steroids. But the short-term first-year outcome is certainly far from us being able to satisfy. So there's a great unmet need for us to improve. And that's why something like complement inhibition has become such an important aspect in ANCA-associated vasculitis now. And we could say, why have we not looked into complement inhibition earlier? And I don't think we need to blame anyone on that, because if we look at how we define our diseases and look at how we divide our rapidly progressive glomerulonephritis, remember that it's easier to look at type 1, where you have this nice linear deposition of an IgG that directly activates the classical complement pathway in anti-GVM disease, or the type 2 immunocomplex diseases. As Juan just pointed out, there's so much deposition of so different immunocomplexes and complements that we actually wonder where the mechanisms is and what to block, compared to what we said to our disease. ANCA-associated vasculitis causing porous immune disease. And porous immune meaning that tiny bit of complement deposition we perhaps see is a mild C3 that in an EM only leaves a vague sparse deposit. And so no wonder that we'll perhaps delayed get involved with complement inhibition. But if you look into stainings first, porous immunity does not mean non-immunity. And on the left side, you see the complement pathway here, from my side very simplified. And I would want us to just concentrate on, we have the alternative pathway as AP, the classical pathway as CP, and then downstream with the C3 convertase, we'll have the release of anaphylatoxins like C3A, and further downstream C5A and their receptors. And novel complement factors and staining of other factors than the two classical factors we routinely stain, so not staining C1q and C3, but staining other factors in the last years, has hinted at that there's some involvement of complement, because the so-called porous-immune ANCA-associated vasculitis, they don't look so porous-immune if you look at these stainings. And these are just examples of C3d staining or a complement factor H related to protein 1 staining from the complement factor H related protein family. So porous-immune on the biopsy, perhaps hinting at this has some mechanism for complement involved. Looking into soluble complement factors, there was also the idea, oh, perhaps we should look into complement. Certainly not, as Juan pointed out, we have this very deep depletion and association between C3 and C4 and the clinical picture in lupus. Far from that, in ANCA-associated vasculitis, you rarely, in a small group, see patients where you do detect the C3 depletion when these patients have active disease. No, you rather have a tiny bit of an increase of C3 and C4 as a general sign of active inflammation, but most of the time you don't find C3, C4 changes in ANCA-associated vasculitis. But I just want to point out, this publication, if you look into more the cleavage products, other complement factors that have been released, that could be a hint what complement is involved in, because in active vasculitis, it was proposed that you do have more C3A and C5A release, and that this calms down when people are in remission. But certainly looking at these hints, the most important studies that have moved towards complement inhibition and increased our knowledge have been the animal studies. And despite all the limitations of these animal studies, and I have just examples from 2 animal studies. One is from the Chapel group from Professor Charles Genette's group, where using a passive MPO transfer model, despite the limitation of passive immunity and not being an active immune model, this model has clinically, not just in the kidney with the crest information, but also in the lungs, nice clinical features, what we find in our patients. So what the group from Charles Genette did is they first had to look and inhibited the classical complement pathway. And inhibiting the classical complement pathway here, C4, and using a knockout mouse for C4, they did find no difference in their mice. These mice were as affected as the wild type. And then depleting the C6 factor as part of the membrane attack complex C5b29, this did not affect the mice either. So these mice showed the same amount of disease with crest information. So that was the first sign. No, the classical pathway is not going to be the one we need to concentrate on. And then not just Charles Genette, but also the group of Ralph Kepritz and Adrian Schreiber looked into the alternative complement pathway. And while Charles Genette used a knockout mouse for C5, Adrian Schreiber and Ralph Kepritz used a knockout mouse for the C5a receptor. And using mice without the ability to bind C5a, indeed what they found is that you see on the right side the wild type with the crest information here, and there C5a knockout mice were protected. So these mice did not develop the disease. Quite impressively, they did not develop crescent and necrosis. So that was the first sign, okay, the C5a receptor axis seems to be involved. And how can we now have a look in humans? What would these factors be used of which effector cells? And most prominently, we know this is a leukocytic classic vasculitis. Neutrophils have a long term been implicated as being powerful in this disease. So if we look at our neutrophils, we do know that neutrophils activated by ANCA release reactive oxygen species. And here, inhibiting the C5a receptor in neutrophils activated by PR3, there was a significant reduction of reactive oxygen species. And further, looking into C5a, where does that come from? Well, so it's not just the C5a binding of the neutrophil, but if we look into neutrophils activated with ANCA and then measuring in the supernatant C5a, these neutrophils released a significant high amount of C5a when they were activated by ANCA. So mechanistically, how do we fear this is going to work? So we have our neutrophil that releases complement factor 5a when it's activated, binds it, and then what does it do with it? So we know nets are involved in ANCA-associated vasculitis, and we see that ANCA induce net formation in neutrophils, but co-incubating the nets induced by ANCA and then co-incubating that with human sera from patients, that actually came to a higher release of C5a. So that we now believe that the pathophysiological processes of ANCA-associated vasculitis are like this. We have our neutrophil crawling along the glomerular capillary and patrolling, and some pro-inflammatory stimuli now prime these neutrophils. And this priming process means that they overexpress MPO and PR3, they come to the surface and they are visible there. And after loss of tolerance and us developing ANCA, these ANCA can bind the neutrophils, and that's the activated neutrophil. And this activation process then has the neutrophils releasing C5a, binding C5a on its receptor. And this is the amplification loop that has done more neutrophils recruited, more primed and activated, and resulting in binding of neutrophils with degranulation, netosis, and the leukocytic classic vasculitis. And with these results, the C5a receptor 1 inhibitor CCX168 called avacopan went into phase 2 trial. And I just have the 2 most important results from there. So giving patients either in green avacopan or in red avacopan with low dose steroids did even show an impressively bigger reduction in your BIVA score of activity in patients compared to the high dose steroids. So the feeling that you could perhaps replace the steroids with avacopan. And interestingly, what we often see when you start treating patients and have a temporary rise even of proteinuria, this did not happen in the avacopan arm or the arm with avacopan and low dose steroids. mechanistically not really telling us is perhaps the toxic effect of steroids and the hyperfiltration causing some protein increase leakage for time that we don't find, or is it just a better control of the disease? But certainly some interesting results. And in the phase 3 trial now, important is, I think, that I show you the design. What was compared was 30 milligrams of avacopan twice daily with the steroid arm, and while the first 26 weeks there was a double-blind, double dummy avacopan with steroid dummy compared to a placebo with steroid. The steroids were withdrawn in that arm at 26 weeks, while the avacopan carried on for the remaining time of the study to the full 52 weeks. And the outcome of that study was that patients did have a similar outcome after 6 months of avacopan compared with steroids. So you were able with avacopan to avoid steroids and replace them and had the same remission rate. And withdrawing them steroids after 360 days, after the full year, avacopan was superior to the arm where steroids were withdrawn. And this has then led the FDA and the EMA now to license avacopan Tavneos in combination with rituximab and cyclophosphamide in severe ANCA-associated vasculitis. And so I come to my last part. This is how has this now featured in the KDIGO and EULA recommendation. And I must say it hasn't featured in KDIGO because KDIGO was drafted before the FDA and EMA license, but it's just featured now in the up-to-date of the EULA recommendation that are to come out any day now. And I think if we look at KDIGO and EULA, we all try to incorporate a bit more the frailty aspect and the severity aspect. But it looks still pretty much like this. So the KDIGO recommendations are using rituximab in non-life-threatening disease. They give the option of MMF, and in more organ life-threatening disease, rituximab or cyclophosphamide, while KDIGO gives you the option to combine rituximab and cyclophosphamide if you feel it is very severe. Then you add glucocorticoids, and the new EULA guidelines will say you can consider to replace steroids or avoid steroids overexposure and add in avacopan. That wasn't in the KDIGO from last year. Both recommend that we can consider plasma exchange, going back to the severity of the disease, while KDIGO says dialysis dependence, creatinine over 500, to consider. EULA will say from a creatinine of 300, and if you feel this disease is driven by an active glomerulitis on the biopsy, then consider plasma exchange as escalation. And KDIGO, as EULA have started to recommend in frail patients to use rituximab as maintenance, and EULA will even recommend first-line rituximab as maintenance. But certainly azacitidine remains the option to that. So summarizing that, I would just quickly like to look forward and say, well, perhaps at some point we'll be able to intervene at the time of loss of tolerance. We're far from there, but we have, I think, already moved now to one further step. We are able to interfere early when C5a is activating and bringing the disease on the neutrophils. The future will show the efficacy of that intervention, and will hopefully open up certain more pathways involving different alternative complement factors, but also have us looking at degranulation of neutrophils and mitosis closer and other cells. And with that, I'd like to summarize. So the deposition of complement in the kidney, and certainly the raised soluble factors as well, have, I think, probably already suggested that alternative complement pathway is involved in the disease. But now we do know that the ANCA-induced neutrophil activation that happens is C5a dependent. And we know that NETs activate the complement and the ANCA dysregulated, so that this positive feedback loop of these three altogether, the alternative complement, the ANCA, and the neutrophil, they drive that endothelial inflammation and ANCA-associated vasculitis. And I've shown you that we've seen in animal models that C5a receptor inhibition was able to completely inhibit the development of the crescentic GN, and that the phase 3 trial now has shown that inhibiting C5a receptor binding is non-inferior to prednisolone in 23 weeks and superior after you withdraw steroids. And that means we can reduce glucocorticoid toxicity, we can hopefully replace it, but I would hope that we also will be able at some point to further improve outcome of patients, and that demands that we have further trials inhibiting the alternative complement factors, and that will hopefully demonstrate how the efficacy of C5a receptor inhibition and investigate further routes.
And as you know, there are unmet needs in lupus nephritis, in several aspects of lupus nephritis, and particularly the results of therapy are far from ideal. And many patients still progress to end-stage kidney disease, and many patients have consequences from our therapies and have adverse events. So we need better therapies and safer therapies. And today we'll look at the complement and see how this pathway is an interesting target in lupus nephritis. Before going to that, I will share with you my view of pathophysiology of lupus nephritis. So to have lupus nephritis, we first have to develop lupus. And patients with lupus have difficulties clearing the immune cells and the breeds from the circulation. So they start getting autoantibodies and forming immune complexes. These immune complexes may circulate to the kidneys or even form at the kidneys, and they will exert an inflammatory response. And this is when we usually see them on clinic with all the clinical manifestations and with complement activation. And finally, lupus goes into a chronic phase, either with treatment or following its natural course. It will go into a repair phase or fibrotic phase. And if the second is the one, then you go into chronic kidney disease and loss of kidney function. Going to complement, you know that complement is a mechanism of defense for our bodies against microorganisms, and it can be activated through 3 different pathways. The first one is the classical pathway, and the classical pathway is activated by antigen and antibody complexes, just as immune complexes in lupus nephritis. So they bind to the C1 complex and activate the pathway. Another way to activate complement is by the lectin pathway. And this pathway has several proteins that have terminal domains that can bind to sugars in bacteria, but also in apoptotic cells. And once they bind to those cells, they next bind to MASPs, or mannose binding lectin activating serine protease, and then they can activate C4. So when we measure serum C4 in our patients, we are looking at activation of complement by the classical or the lectin pathway. A third way to activate complement is by the alternative pathway. And this pathway, you know, is continuously activating by a tick-over mechanism and also inactivating. But once in contact with activating cell surfaces and with the help of some other proteins like factor B, factor D, the alternative pathway is a potent way to activate complement. And all 3 pathways join into a common pathway in C3 and C5 activation. Finally, this pathway will exert its functions or damage through 3 mechanisms. The first one is by forming the membrane attack complex, and that forms pores into the cells and produces cell lysis, but also by producing some complement fragments like C3a and C5a that bind to their receptors in immune cells and attract some inflammatory cells and produce inflammation. And a frequently forgotten function of the complement is that many of these particles can function as opsonins, particles that bind to the surface of the cells or cellular debris and mark them for clearance from the circulation by phagocytosis. And finally, there are multiple inhibitors of these pathways. So this complicated figure can be seen like this, and this is the scheme we will be using during this presentation. You can see above the 3 ways of activating the complement pathway, and below the 3 mechanisms of action of the complement: inflammation, cell lysis, and opsonization. So let's go first to why the complement has a protective role against developing autoimmune diseases. And this is because we observed from many years ago that mutations in some complement proteins, particularly those in the early classical pathway like C1 and C4, predispose patients to developing lupus. And this has also been corroborated in animal models with knockout for C1 or C4 proteins, and these mice models develop lupus, and many of them also lupus nephritis. And more recently, also mutations in the early lectin pathway have shown a higher risk for developing lupus and lupus nephritis. So as you can see in this slide, there are multiple ways of predisposing to lupus. So the effects in opsonization, and this is on particles in the early classical or lectin pathway, facilitate the development of autoimmune diseases. And this happens because these particles usually bind to cellular debris in the circulation, and once bind, they mark this cellular debris for removal by macrophages, erythrocytes, or any cell that has the complement receptor. In fact, in the circulation, the CR1 receptor, 90% of the CR1 receptor is in the erythrocytes. And interestingly, CR1 is also present in the podocytes. So if we don't have these particles, opsonizing particles, or their levels are too low, then the cellular debris will remain in circulation, and patients with predisposition to develop autoantibodies will form immune complexes, and we saw that these immune complexes will go to the kidneys and produce the lupus nephritis. So there's a protective role for complement, but also there's a damaging role for complement in lupus nephritis, particularly in the inflammatory phase. And I'm going to show, we've seen this through the years by several studies. I'm going to show some studies first, genomic studies that try to find polymorphisms or gene variations that predispose to developing lupus nephritis particularly. So we've seen that the classical pathway, complement pathway is involved, and also its inhibitors, but also proteins in the common pathway, in the alternative pathway, and the lectin pathway may predispose to develop lupus nephritis. So as we see in this slide, any of the pathways may be involved in producing lupus nephritis. Let's move now to tissue transcriptomics. And these studies try to see what genes are expressing directly in the kidneys of patients with lupus nephritis. And again, many proteins from the classical pathway, genes are overexpressed from the classical pathway, but also in the common pathway and also in the alternative pathway. And interestingly, the inhibitors of the complement are decreased. So any of the pathways leads to developing lupus nephritis. And what about mechanisms? Well, there are many studies showing that C3a, C5a, and their receptors are overexpressed in the kidney tissue, but also the membrane attack complex is overexpressed in kidney tissue, and this is particularly true in the tubular interstitium. So any pathway or any way of producing damage is involved in lupus nephritis. Of course, not in every patient, and this is what is difficult in lupus nephritis. And finally, I want to show you these studies. We usually in clinic look for proteins that deposit in the kidneys. We usually see C1q and C3c in the biopsies of our lupus nephritis patients. Some other groups routinely stain for C4d, and it's interesting that C4d deposits following the same pattern as the lupus nephritis class. But many other groups have shown particles from the alternative pathway or proteins like properdin, and particles of protein from the lectin pathway. So again, lupus nephritis may be triggered by any of the pathways and by any of the mechanisms of damage. We have seen deposits of the C3a and C3a receptors in the glomeruli and of membrane attack complex in the tubular interstitium. So what to get from all this? Of course, it's pretty evident that complement activation participates in the inflammatory phase of lupus nephritis. I am not going to talk of animal models, but inhibiting complement in animals prevents damage from lupus nephritis. So what is the actual problem? The actual problem is heterogeneity. And it's heterogeneity between patients because some patients are activated through the complement is activated through the classical pathway, some other through the alternative. There may be a combination. There may be one in the glomeruli, other in the tubular interstitium. And we lack biomarkers to know which pathway is active and which mechanism of damage is acting in each patient. And before going to treatment, I want to show you why in that chronic phase of kidney disease, when fibrosis develops, there's possibly involvement of the complement too. And the rationale is that in many proteinuria diseases, it has been shown that filtered proteins activate complement that deposits in the tubular interstitium. And you can see in the image how the membrane attack complex can be found in lupus nephritis, but also in diabetic nephropathy. Particularly in lupus nephritis, these deposits of the membrane attack complex have been associated with a worse prognosis and have been shown to happen even in patients without active inflammation, patients with chronic biopsies. And we know there is a group of patients with lupus that, although has a response, a partial response, they remain with subclinical inflammation. They remain expressing some biomarkers, like here I show you a graph for MCP1, and these patients are the ones who progress in their kidney disease. So maybe there's also a role for complement inhibition in this chronic phase, not only lupus nephritis, but in many proteinuric diseases. So let's jump into complement as a therapeutic target, and moving forward to treatment. There are many questions. Some of them are here. First, we can question which pathway to target. We know that we have to avoid inhibiting the early classical pathway, to avoid inhibiting those opsonins that help eliminate the cellular debris, but it's not so clear if we have to go for the alternative pathway, the common pathway, if we have to go for anaphylatoxins and their inflammatory damage, or to the membrane attack complex, or maybe a combination of them. Many studies have focused on the alternative or the common pathways, as these are the most potent ways of activating complement. Another potential question is what combination of immunosuppressors, because we're going to inhibit complement and we don't want to interfere with the function of other immunosuppressors. And for example, in animal models and in vitro experiments, glucocorticoids, mycophenolate, and cyclophosphamide have shown to decrease complement activation, while calcineurin inhibitors have shown an increase in complement proteins. I don't see a potential problem in this because there can be a synergy or a complementary function of complement inhibitors with these medications. However, rituximab and many monoclonal antibodies, once they bind to the B cells, they exert their action by using complement, by complement-dependent cytotoxicity. So if we inhibit complement, then we will be antagonizing the functions of rituximab and other monoclonal antibodies, and maybe they won't work as well as without the complement inhibitor. So maybe that's the only combination that is not good to study. And the other thing is when to use. Of course, the most logical answer is to use during the inflammatory phase, but we need biomarkers to show what pathway or what mechanism of damage is active in an individual patient to have better treatments. And as I mentioned before, there may be a role for these medications in the chronic fibrotic phase. So what's active right now in the study, in what clinical trials we have in lupus nephritis right now? There are 4 clinical trials. The first one is narsoplimab, an inhibitor of MASP2 protein in the lectin pathway. Iptacopan, that's an inhibitor of factor B in the alternative pathway. We have pegcetacoplan that inhibits complement C3 protein, and we have ravulizumab that inhibits C5 just as eculizumab does. And I want to also mention avacopan. There's no active trial of avacopan in lupus nephritis, but it's a potential target as it can decrease inflammation in lupus nephritis. So at this moment, there's no indication outside clinical trials for complement inhibitors in lupus nephritis, in classical immune complex lupus nephritis. However, there is one suggestion to use complement inhibitors in a non-classical lupus nephritis, and that is the case for thrombotic microangiopathy. Thrombotic microangiopathy may be found up to 18% of lupus nephritis biopsies. And this is an histological diagnosis showing vessel occlusion that may be secondary to several etiologies. And we have to look for the particular etiology in each patient. And the problem is that TMA or thrombotic microangiopathy is associated with worse prognosis. And many studies have shown the participation of the alternative and common pathways in the development of thrombotic microangiopathy. This is one study from our group, and we measured complement fragments in plasma and in the urine of patients with active lupus nephritis, but also in patients with active lupus nephritis plus TMA. And as you can see at the bottom, you can see that the C3A, BA, C5A, and the terminal, the membrane attack complex are elevated in serum and also urine of these patients. And we had 2 patients with recurrent episodes, and it's pretty clear how these fragments that translate activation of the alternative pathway elevate during the acute episode and then go down at remission, then go up again once there's a new acute thrombotic microangiopathy episode. So these and many other studies led KDIGO to put this algorithm for management of thrombotic microangiopathy in lupus. And the first step is to go to study these patients by ADAMTS13 activity and antiphospholipid antibodies. And in a subgroup of patients with normal ADAMTS13 activity and no antiphospholipid antibodies, there are some patients with complement-mediated thrombotic microangiopathy that may benefit from complement inhibition with eculizumab. So this is at present the only indication or suggestion to use complement inhibition in lupus. So the take-home messages are: first, we have to acknowledge that there's a protective role of the complement pathway against development of autoimmune diseases. It is pretty clear that during the inflammatory phase of the disease, complement is activated. The problem is that there is large heterogeneity among patients, and we need to find biomarkers to get to an individual treatment. Current studies of complement inhibition are focusing on the alternative, the lectin, or the common pathways. And keep in mind that there may be a role of complement inhibition in the chronic phase of every proteinuric disease. And for now, the only indication or suggestion to use complement inhibitors is in the cases of complement-mediated thrombotic microangiopathy. And this is all for me. Thanks for your attention, and thanks for your questions.